Well, I'm John Ward. I'm from MD Anderson. I was asked to talk about really the impact of MRI on prostate biopsy. And I think the talks that we've had leading into this are just perfect to lead up to this, because we discussed first with our first two presenters the use of PSA and how do we identify men that we should even be doing a biopsy in. We heard about the USPTF recommending against prostate biopsy primarily because of the complications that occur with it and because of the finding of low-grade cancers that we just heard are not going to eventually kill patients. And so we then, this leads us very nicely into, well, how do we go about diagnosing prostate cancer? So I'm going to go through where we are with the prostate biopsy process and why I think we may be undergoing sort of a paradigm shift in the way we approach things, but also point out with all of these trials that Dr. Crawford just mentioned, some of the failings in this. And I think as urologists, we love to jump on board with new things, and then we sort of backtrack ourselves a little bit. And we may see that we actually end up doing that, and so it'll be interesting to see the debate that Dr. Crawford moderates at the AUA, which I unfortunately won't be going to now. Okay, same problem as everybody else. Okay, where is it here? Is it down here? Will the roller work? And, oh, yeah, it does. Okay, just not so fast. Okay, have to do it up. Okay, so I have no disclosures. Nobody's supporting me with anything. So this is the agenda, to go through what the problem is, to go through a bit of MRI imaging, and we're going to do it a little bit out of order there. So what's the problem? The problem is, I can't get the roller straight. The problem is that this is how we've always approached men who we suspect as having prostate cancer. Even back prior to the days of PSA, we approached men who we thought had prostate cancer by essentially rebiopsying their prostate and rebiopsying their prostate and rebiopsying the prostate, because we never knew what the true negative value of a negative biopsy was. This is a typical example of a gentleman who's had a PSA that slowly rises over the years. What we saw when we go back, back to when I was a resident back in the 90s, we saw that we went from having just a 6-core prostate biopsy all the way up to even a 100-core prostate biopsy, where we're doing these saturation prostate biopsies to identify a prostate cancer. Going the wrong way again. So if we had a patient with a rising PSA, the traditional approach, if we had a negative biopsy, was just to keep him on annual screening, bring him back in a year, find out that the PSA was elevated again, and then go ahead and rebiopsy. We were rewarded through our persistence if we found a significant prostate cancer. And we just had a couple of nice talks on how finding significant prostate cancers can impact the prostate cancer specific mortality. However, we had a lot of failure in this approach. A lot of failure in that we would eventually find 1 or 2 cores of Gleason 6 prostate cancer, oftentimes in a 70-year-old man or older, who we've just spent the past decade scaring about prostate cancer, telling him he has to come back next year for another PSA check and another biopsy, probably his 6th or 7th biopsy, finally find a little bit of prostate cancer, and now we tell him, wasn't anything. I didn't need to put you through all of those prostate biopsies. That's a real failure of the system. You can see why patients who are very confused, it confuses me to have to sit there and explain this to a patient, why I just made Swiss cheese of his prostate and tell him now that I don't want to do anything. So what are we really trying to do when we try to do a prostate biopsy? It's obvious. We're trying to identify clinically significant prostate cancer, and as we just heard, we really want to find those Gleason 4 components or the cribriform component, whatever component of that is, that significant prostate cancer, the working end of the prostate cancer, as we just heard. We want to avoid overdiagnosing prostate cancer. We just found out from our prior talks that overdiagnosing Gleason 6 prostate cancer is not going to help anybody, and in fact, it oftentimes hurts the patient in multiple psychological and even insurance reasons. And we want to try to minimize the cost, patient discomfort, and avoid the complications that occur with the prostate biopsies. These aren't to be taken lightly. I mean, if we do about 1.2 million prostate biopsies a year in the United States, that's an enormous cost, and we can go through all those different costs. Patients don't like prostate biopsies. I currently do all of my prostate biopsies under just some sedation. Propofol is a wonderful drug, and if you have a system that allows you to turn over 15 patients and do a prostate biopsy under propofol, haven't had anybody complain. And you need to avoid the complications, which we can go through. This also helps us address personalized medicine. That's the buzzword in medicine these days, is being able to personalize the medicine. And we can go on to talk about how we combine different therapies if we have these higher grade cancers that may need more than one modality, and we're going to hear in future talks throughout this weekend about other interventions that can be done on top of prostatectomy or on top of radiation therapy to improve things. And so one size doesn't fit all. It used to be that once you found the prostate cancer, you put it in a bucket and that was it, or you irradiated it and that was it. Now we should be able to personalize the prostate cancer treatment better if we can only have a better way of diagnosing the prostate cancer and know that what the biopsy represents will be correlated with what the prostatectomy specimen says. So we've tried to improve this multiple ways, as Dr. Crawford went through. We had PSA isoforms, nomograms. We've done what I call carpet bombing of the prostate, where we increase the number of needle biopsies. It was a slow needle prostatectomy. I can't tell you the number of patients that I've done their 9th or 10th biopsy on, and it just feels wrong. We've used urine markers and tissue markers that Dr. Crawford is going to talk more about. We've used nomograms. This is a very commonly used nomogram. It's the PCPT. It's based upon the PCPT trial. These are nice. This is a nice simple nomogram to show a patient who's considering a prostate biopsy, and you show a patient with these various characteristics that the only cancers that we really want to find are these ones down here, as we just talked about. So if we have a patient who comes in with, I forget exactly what the parameters were that I put in here, but he only had about an 8% chance of finding a significant prostate cancer. The caveat about a lot of these nomograms is that these are based on the historic biopsy technique. And so I start to wonder just how much these nomograms are going to come into play now that we're doing more image-guided biopsy techniques. So let's talk about the image-guided, if I can get this right, image-guided biopsy techniques. Dr. Crawford's going to talk a little bit about this tomorrow. So what we really need to do is, I was in the military for 20 years and we delivered ordnance on target. Ordnance on target, that's what we'd call it. You want to put that missile on the target. You want to put your rifle, your whatever on the target. You don't want to have the napalm effect of just carpet bombing the prostate to find out where it is. What we have always done in the past is used our imaging just to find the prostate. Some of the ultrasonography that we have, as urologists, have become accustomed to, I now look at being a better ultrasonographer myself. I look at some of these older ultrasonography machines, and it is pitiful what we as urologists put up with for our tolerance for good imaging with the ultrasound, because all we were trying to do was find the prostate. We went from doing finger-guided prostate biopsies back right at the beginning of my residency to doing ultrasound-based biopsies, and really it was just to find the prostate and to try to distribute the random prostate biopsies throughout the gland itself. Now we want to be able to see where the tumor is and put a needle on it so that we can go back to all of the nomograms that Dr. Lucia just showed and say, this is what your risk is of dying if we do this for the prostate cancer or not, and feel confident that if we took out the prostate, we would find what we actually see on the prostate biopsy itself. That has been the problem. So, multiparametric MRI imaging of the prostate. This has actually been around for quite some time. I can remember being up at Mayo back in 2000 and having our first lecture on multiparametric MRI. But at that time, we clearly knew that we could see prostate cancer within the gland, but we weren't quite sure how to get at it. And so we did a lot of different things. Multiparametric MRI is a functional form of an MRI. It supplements the anatomical forms of an MRI, the T1 and T2 weighted images. What you have within the multiparametric MRIs are functional sequences. You have a dynamic contrast enhancement, you have diffusion weighted images, and then you have a calculation of apparent diffusion coefficient, which actually comes out of the DWI mapping. So it's a laborious process, much more complicated than just having a chest X-ray, a CT scan, or even a T1, T2 weighted MRI of anywhere in the body. There's challenges to doing a multiparametric MRI. The MRI machines themselves are all over the map. These are very expensive machines, and people are now trying to employ older MRI machines, not necessarily with weaker magnets, but potentially with weaker software in order to get prostate MRI imaging. There's the whole question of putting an endorectal coil in the rectum or not. All of these things we can debate, but it's a lot more complicated than just having a chest X-ray or CT scan to get a good MRI of the prostate. There's heterogeneity of image quality between centers, and this just multiplies as you go, or it just snowballs as you go through what it takes to get a good MRI of the prostate. Right from the beginning, when the tech first starts that MRI, anything that goes on from there just multiplies if you have a little error at the beginning. It's dependent upon the magnet strength, the number of coils, the number of channels, the endorectal versus the surface coil that we talked about, the field of view of the MRI, small versus large field of view, and software upgrades. I've become amazed at the software that's behind many of these MRI machines and some of the ways that you can improve the imaging just by changing the software. Some of our 3T magnets that we currently have at MD Anderson are not nearly as good as our 1.5T magnets because of the software, and you can see this whenever they do the upgrades. There's also various protocols employed, so again, it's not a simple study. The sequences, parameters, the choice of B values, when you really get into understanding what an MRI is, the choice of B values plays in a lot, and so all of these make it difficult. So this is a short way of saying it takes a large team to do good MRIs of the prostate and to do good MRI fusion biopsy of the prostate, which is what we're about to talk about. It's not as simple as just sending a patient to an MRI center and getting an MRI and seeing if there's a PIRADS 4, PIRADS 5 type lesion there. Even those type of readings can be horribly off because you had a poor quality MRI to begin with. The other thing about an MRI is it is not, despite what we may have thought at the beginning, and I'm not going to go through the literature on all of this, but at the beginning we were receiving quotes of the MRI being sensitive and specific for high-grade prostate cancer with numbers approaching 100%. But I give to you this example of a patient who had clearly had two high-risk lesions within his MRI and the T2 and DWI weighted images, and you get the prostatectomy specimen out, and you see that the patient actually had other cancers as well. Now, to some degree, this is a win, because you can see these two other cancers that were sitting over here were low-grade cancers and low-volume prostate cancers that may have not affected the patient at all. But it is good to understand what the MRI is capable of telling you and what it may actually still be missing. So the current state of affairs, there are numerous papers, as Dr. Crawford mentioned in introducing me, that go into the MRI-guided prostate biopsy, both in prostate biopsy, in biopsy-naive patients, as well as in patients who've had prior negative biopsies and are heading down that pathway of annual prostate biopsies because of an elevated PSA. But I'm going to try to focus really just on 3 trials that I think really form the foundation of where we are with MRI-guided biopsies. The first trial comes out of the NCI, and in this trial, this was a trial for men, ultrasound-guided biopsy for the diagnosis of prostate cancer. Eventually, it ended up enrolling about 1,000 men. All of the men had an elevated PSA. They underwent a multiparametric MRI and had at least one visible lesion on the MRI. These men then underwent a targeted MRI ultrasound fusion guided prostate biopsy. So they had to think about this for a second. So they then underwent either an MRI fusion guided prostate biopsy or a standard trust biopsy, and you can see the number of cancers that were diagnosed in the two groups were essentially the same. So they were getting about the same number. If you just look at overall who was diagnosed with prostate cancer, you can see that about 800 of those 1,000 patients were diagnosed with prostate cancer, all of them having MRI abnormalities prior to undergoing a biopsy, and that in this study, doing, at least at initial glance, doing an MRI fusion biopsy didn't change the overall detection of prostate cancer. And that would be fine if all we had was a one-size-fits-all approach to prostate cancer, and that's really what we used to have, is just a one-size-fits-all. We would just put the prostate in a bucket. There was an exact agreement between the targeted and the standard biopsy with regards to grade in about 70% of the patients. The targeted biopsy, however, diagnosed 30% more high-risk prostate cancers than the standard biopsy. So that was leaning towards this MRI fusion biopsy technique, being able to identify the patients that we really wanted to identify better than the men who underwent just a standard prostate biopsy. And it also avoided identifying men who had low-risk prostate cancer, so getting away from this overdiagnosis of low-risk prostate cancer. Only 170 of these men, which is a little bit disappointing, out of the nearly 800 men, 900 men who underwent prostate biopsy, actually went to prostatectomy and have whole gland pathology to compare to. The problem with this trial, and this is a very nice table that sort of outlines all the findings of the trial, the problem, where did I put it? The problem with this trial is that 80% of these men actually had already had a prior negative biopsy. So this goes back a bit to a lot of the PSA studies, and that this group of patients was already pre-populated by a group of patients who'd undergone a negative prior biopsy. So it doesn't quite fit in with where we are with dealing with men who are newly coming for a prostate biopsy, or even men who have a prior negative prostate biopsy. It didn't quite answer that question. But it certainly did lead us to the direction that we were finding more significant prostate cancers doing a fusion biopsy than with the standard prostate biopsy itself. Am I going the right direction? Wrong direction again. Here, the pre-selected group with 80% having prior biopsy. I knew I had that in here someplace. And you can see that up here in this group. And this is a nice table from that, just showing the difference between the two groups. So let's move on to the second trial. The second trial is called the PROMIS trial, and it's a diagnostic accuracy of multiparametric MRI and trust biopsy in prostate cancer, a paired validating confirmatory study. This study was a little different than the prior study in that all of these patients had never had a biopsy before. They were all prostate biopsy naive. So I'm getting back to that whole question of, you have the PSA screening going on, when do you biopsy and how do you do that initial biopsy, not the men who had previously had a biopsy. These men had no prostate biopsy. They could have a PSA of up to 15, and the test was looking, what the study essentially did was a test diagnostic accuracy of multiparametric MRI and trust biopsy as a reference test against a template prostate biopsy being the reference test is really what it should say there. So it was a fusion biopsy versus a trust biopsy using a template biopsy, which Dr. Crawford briefly showed in his first talk, as the reference. So whatever the findings were on the template mapping biopsy that was performed transperineally, that was considered the gold standard. Rather than a prostatectomy specimen, the gold standard was taking the man, putting essentially 60 prostate needles into his gland and calling that the accurate test against which we were going to measure either an MRI-guided prostate biopsy or just a standard prostate biopsy. All men underwent a 1.5T multiparametric MRI, trust biopsy, all men underwent a trust biopsy and then a template biopsy in all men. And clinically significant cancers were here. The primary objectives were to establish men who could safely avoid prostate biopsy and correctly identify on multiparametric MRI whether or not the patient had prostate cancer. So this, wrong way again. So this trial was not a trial comparing necessarily the multiparametric MRI ultrasound fusion-guided biopsy technique versus doing a standard biopsy. This was a trial that was really looking at whether or not the MRI provided a negative predictive value for prostate cancer. This gets back to what Dr. Crawford was saying earlier of wanting to be able to be assured that the patient doesn't have prostate cancer there. And this could be considered even another biomarker, is what they were trying to prove. They were trying to say that if you have a negative MRI, you can assure the patient that he doesn't have prostate cancer. And that's really the key to the PROMIS trial, but it's an important factor in what we're about to talk about in the precision trial here. Essentially what they ended up finding here was that the prostate, having a negative MRI reduced the risk of finding prostate cancer by it doesn't come up here, but it's by 27%, the reduction in risk of diagnosing insignificant prostate cancer by doing a multiparametric MRI and ruling those patients out. There was, and so they used this 27% number to move into the precision trial out of the PROMIS trial. Wrong way again here. One of the things that they looked at in the PROMIS trial was the complication rates, and these are the complication rates: pain and discomfort, hematospermia, urinary retention, and this was particularly high in all of these patients because of the template biopsy and the number of cores that were required to do that standard, gold standard test. So the conclusion was the multiparametric MRI to triage men allowed 27% of patients to avoid a primary prostate biopsy. In other words, a negative MRI of the prostate was a accurate predictor that they would not find any prostate cancer on the template mapping biopsy in 27% of the men. It also allowed them to triage men to avoid diagnosing 5% of men with clinically insignificant prostate cancer, and that trust biopsies directed by multiparametric MRI would identify 18% more cases of high-risk prostate cancer. So just to try to clarify it even for myself here, it looked at MRI and whether or not it would serve as an accurate negative predictive test for the presence or absence of prostate cancer, and found that 27% of men, if they had a negative MRI, would be able to avoid a prostate biopsy because it was accurate in that fashion. It also would allow 5% of men who would be diagnosed with insignificant prostate cancer to avoid having a prostate biopsy, and that it allowed identification through a fusion technique of 18% greater high-risk cancers. And so the authors concluded that you should use a multiparametric MRI as a triage test before doing a first prostate biopsy. So you get a PSA, you think the patient needs a prostate biopsy, you get an MRI. If you don't see anything there, you can feel with fairly high confidence that they don't have a prostate cancer there. If you do see something there, you should go on to a fusion biopsy. So that leads us eventually to the precision trial here. And the precision trial, the title of the New England Journal article is MRI Targeted or Saturated Biopsy for Prostate Cancer Diagnosis. It's called the Precision Trial Prostate Evaluation for Clinically Important Disease, Sampling Using Imaging Guidance or Not. And it was published in the New England Journal last year. So this precision trial here that you hear a lot about actually involved 25 centers in 11 countries. And this is one of the critiques that this gets, is this comes all the way back to the beginning of my talk, in that MRIs across different centers are very different and very difficult to interpret. That's going to be one of the critiques. It's a randomized non-inferiority test in which men had a PSA less than 20 or an abnormal digital rectal examination or both as the indication for the prostate biopsy. The intervention was that all men who had some sort of reason to undergo a prostate biopsy underwent a multiparametric MRI. If the multiparametric MRI demonstrated a PI-RADS3, and again it comes back to the radiological interpretation of that MRI, they were randomized to either undergo an MRI ultrasound fusion-guided biopsy of the prostate or a 12-core biopsy of the prostate, systematic random biopsy of the prostate. One of the other criticisms of the trial comes into this arm here, that if the multiparametric MRI was not positive, that they had no biopsy performed at all, and they don't actually present any information on this group of men who had an elevated PSA or a digital rectal examination, what went on to happen to those. And it turns out about a third of patients who underwent an MRI for this for an indication for prostate biopsy had nothing there and never underwent a prostate biopsy. The primary outcome was clinically significant prostate cancer. The secondary outcome was clinically insignificant prostate cancer. This is how it actually worked out, sort of a map here, and this is a comparison of the precision with the normal MRI based on PROMIS, and this is how they came up with the number, was based on the number of patients that they needed to examine, was based upon the PROMIS trial and having a 27% negative predictive value for the MRI. So 500 men in the precision trial underwent randomization. MRI targeted biopsy groups, 71 of the 252 men within the MRI targeted biopsy group had results that were not suggestive of prostate cancer, so they didn't undergo any biopsy. Of the MRI targeted biopsy group, clinically significant cancer was identified in 38% of men. In the standard biopsy group, in other words, they did have something on their MRI, but they didn't undergo an MRI fusion biopsy, the detection of clinically significant cancer was down to 26%. And this was a clinically significant difference in the detection this was a statistically significant difference in the detection of clinically significant prostate cancer between these two numbers here. So the results, the MRI with or without targeted biopsy was non-inferior to the standard biopsy, and fewer men in the MRI targeted biopsy group than in the standard biopsy group received the diagnosis of clinically insignificant prostate cancer. And so it met all the criteria for being superior to a standard biopsy, both in the intention to treat analysis, a modified intention to treat analysis. All of the outcomes are sitting on this side of the line here. Again, it comes back to complications in that you saw that patients who had an MRI-guided biopsy, and the MRI-guided biopsy was only of the target, not taking random samples from elsewhere outside of the prostate biopsy. So they had on average 6 prostate biopsies taken compared to on average 12 or more prostate biopsies in the trust group. You saw that with fewer biopsies, you had less complications associated with it, which is what they were hoping to find, that you could reduce the risk of complications by using an MRI fusion technique to reduce the number of biopsies obtained. So the proponents of MRI first say that it has a high negative predictive value that comes from both the precision trial and both from the PROMIS trial and the precision trial, and it increases the detection of clinically significant prostate cancer while decreasing the detection of clinically insignificant prostate cancer, and that overall it will reduce the costs and improve quality of life by reducing the number of biopsies that are needed and the risk of complications. It also importantly gives a better understanding of natural progression of negative MRI patients. However, we need further evaluation of this through markers, as Dr. Crawford was talking about earlier. One of the issues with this comes into trying to do an MRI on all of these patients. You know, at MD Anderson, an MRI of the prostate costs about $5,000, while at East Jefferson in Louisiana, it costs only $700, and in the UK, $200. So again, the healthcare dollar, how far are you going to be able to stretch it, and why are there these great differences in the costs? There's considerations on changing the way that you do a multiparametric MRI. Maybe you only need a biphasic MRI compared to a multiparametric MRI. A biphasic MRI would take 15, 20 minutes as opposed to a multiparametric MRI taking nearly an hour. And do you do just a screening MRI? Do you do a screening MRI with a pelvic coil or with an endorectal coil, and potentially even avoid the PSA question altogether? And that's about it. So thank you very much for your time.